Welcome to the workshop, Cognitive Challenges After Transplant and CAR T-Cell Therapy and Their Treatment Options. It's my pleasure to introduce today's speaker, Dr. Zev Nakamura. Dr. Nakamura is a psychiatrist and a clinical researcher at the University of North Carolina School of Medicine. He supervises a psycho-oncology training clinic that addresses cognitive and other neuropsychiatric concerns of cancer patients undergoing various cancer treatments. Dr. Nakamura research involves evaluating patient-reported cognition outcomes, understanding how other psychosocial and biological variables impact cognition, and testing pharmacological and behavioral interventions to prevent or treat the cognitive consequences of cancer and cancer care. Please join me today in welcoming Dr. Nakamura.
Thank you so much for having me. Today there are a few main things I'm hoping to cover. The first is to discuss how common cognitive problems are in people who have received stem cell transplant or CAR T therapy. I want to give a little bit of people a sense of how long these cognitive difficulties last and sort of how they might change over time, including the degree to which they're reversible, and then conclude with a discussion of treatment options, including sort of lifestyle modifications that anyone can and should do to help maintain and improve their cognitive function. So I wanted to start by just a brief history about kind of this area of cancer and cognition. So the very first report of cognitive problems related to cancer and cancer treatment actually was a paper published in the 1970s in the American Journal of Psychiatry. But there was very little sort of recognition or interest in this area for several decades. Things started to change in the 90s when the term chemo brain was described from the breast cancer patient community, and people started to look more in depth about the types of cognitive problems that patients with cancer experience, initially with really a focus on chemotherapy. We didn't have our first study showing how these cognitive changes might evolve or change over time until 2004. And then the last 2 decades, I would say, have really, there's been a lot more focus of this area. And with that increased focus, we've learned that these cognitive problems are not specific to chemotherapy, but can occur with a wide range of cancer treatments and perhaps even from just the cancer itself. So when I refer to cognitive problems, I'm really talking about a wide collection of symptoms. So some of the things that I hear patients describe to me is that they have difficulty sort of finding the word that they're looking for or the right word. They might describe difficulty when they need to multitask or tasks get more complex, both in terms of what people describe and what we see on cognitive testing include declines in or worsening concentration and focus, slower thought processing speed, difficulty with sort of how people might approach or plan for or strategize to do something sort of in their everyday life that might, again, involve multiple steps. And then memory is definitely an area of cognitive function that's impacted by cancer treatment, and definitely the language that I hear most from patients. Specifically, patients will often say that their long-term memory is fine, but their short-term memory is substantially impacted, and we might be able to have time later to talk about what that might mean exactly. So I wanted to next share this image from a, at this point, pretty old research study of 2 twins, and it'll take me kind of a little bit to orient you to this. So what you're looking at here are what they call functional MRI scans. And what functional MRI does is it shows in color, and you can see the red, orange, and yellow here, how much brain activation is happening, or another way to think of that is how hard the brain is working. So I mentioned that there are twins depicted here. So in the top row, row A, is the brain of a woman with cancer who's undergoing chemotherapy. And then in row B is her twin sister who hasn't had cancer, hasn't received cancer treatment. Now, as you move from left to right, you're seeing their brains and the amount of activation or how hard they're working as they're asked to do an increasingly difficult cognitive task. So the healthy sister in row B, you see the expected pattern, which is when the task is really easy, there's very little activation. But as she's asked to do something harder and harder, she's using sort of more brain power to complete the task. But you see something very different in the sister with cancer in the top row. You can see that even from the easiest version of the task, her brain is having to work quite hard. When you compare these fMRI scans to cognitive function, both asked of them and tested, that's where things start to get interesting. So if you ask these two women how good they feel like their cognitive function is, you see massive differences between the two sisters. So the sister with cancer says she's really struggling, and that fits with what we're seeing here on the fMRI scan. But by comparison, on the testing, though the sister with cancer did do worse on the test, it was actually just marginally worse. And this is a really common pattern we see across cancers and across cancer treatments, which is that there is an impact on cognitive function that you can test, but that in general, that impact is quite small, whereas the impact on how much cognition feels like it's been affected to the patient is much larger. So, said a different way, in general, for most people, the cognitive changes or cognitive decline that occurs with cancer treatment is usually subtle or small, but for some people, the effects still can be large. But even in those people where they've experienced just a small decline in how well their brain is working, we know from the research that even these small declines can have major impacts on work abilities, emotional and social well-being. It might impact either their ability or their confidence to do everyday important things like manage medications or pay bills. And then it also may increase risk for long-term cognitive difficulties. So now let's turn to how common these issues are and how long they last. So again, interestingly, even though the majority of the research has happened with respect to chemotherapy and also in the breast cancer population, we see a lot of consistency across cancers and cancer treatment. So sort of regardless of the treatment, we find that if you evaluate a group of patients before they get whatever it might be, so chemotherapy, stem cell transplant, CAR T, about a third will have worse than expected cognition relative to, healthy people of similar age and race and educational background. And then when people actually receive treatment, a much higher percentage will report that they are noticing difficulties or having decline, and that this gets better in many people, but does persist in a subset, and that subset, you see more variable numbers there. So anywhere from like 15% to 50% may have sort of persistent difficulties for years later, but on an individual level, we see quite a bit of variation, and I'm going to try to illustrate that variation here with the plot you see already, and then the one I'm going to add on in just a moment. So these plots, they come from a study of around 1,000 patients with breast cancer, and they're showing changes over the course of chemotherapy. And the reason why I'm showing these figures here from breast cancer is because, again, that's kind of where the sort of most research has happened with the largest patient samples and sort of gives us the best sense of these things. But I'll turn towards, unique factors with transplant in CAR T in just a moment. So in any case, what you can see here is the breast cancer chemo group is in yellow and healthy controls are in blue. And so even pre-treatment, so that's the time point on the furthest left, they are reporting worse cognitive function than their healthy peers. And then you can see when they're evaluated on the other side of chemotherapy, there's actually substantial worsening of their report of their cognitive function. And then if you follow them up 6 months later, on average, people are doing better, but they're still not doing as well as they were doing prior to chemotherapy, and certainly not as well as healthy folks, again, of similar sort of age, race, and educational background. But what's interesting here is if you pivot from the sort of on average changes to looking at subgroups of people, you see a little bit of a different story. So this is focused on changes from pre to post chemo. And if you look now, the chemotherapy group, the colors have been flipped. So now the chemotherapy group is in blue. You can see that, yes, about 45% of people report a substantial or significant worsening in their cognitive function from pre to post chemotherapy. But on the other hand, actually more than half say that they've had no change, or maybe even that their cognitive function has improved. So again, just highlighting that not every person is going to experience the same thing when they go through cancer treatment, but that on average, we see that people have a decline following some sort of aggressive cancer treatment and then a rebounding of their function with time. I wanted to talk just for a moment about this idea of having cognitive difficulties even before you've received a specific cancer treatment. So I mentioned on the other slide that, like, regardless of what cancer we look at or what cancer treatment, if you evaluate people before they go into a particular therapy, about a third show expected then worse cognition. The other thing that's interesting is there's research to suggest that you see some trends in terms of who those people are. So they tend to be people who have more advanced or aggressive cancers, and people who might have certain features like molecular or protein markers on their tumor. And then in terms of why this would be, like why would cancer contribute to cognitive problems, the prevailing theory at this time is that people with more aggressive cancers have higher levels of inflammation, and those increased levels of inflammation are at least one important factor driving the cognitive problems. So now I do want to transition to talking more about the experience of stem cell transplant and what is occurring that is relevant to consider as it relates to cognitive function. So I think the first thing to acknowledge is that, patients who are undergoing stem cell transplant have in general already received multiple courses of chemotherapy. And, the last couple of slides, we were discussing what happens just with chemotherapy alone. And that's just in their history. But even, when you're admitted to the hospital to get a transplant, one of the first things that happens is you again receive a regimen of chemotherapy to prepare yourself for receiving the transplant. And many patients also will get radiation, which also might increase risk for cognitive problems. There's multiple medications that patients who are hospitalized for stem cell transplant receive that may be associated with cognitive problems, like steroids and immunosuppressant medications. Patients who go through transplant are also at increased risk for a variety of infections, including certain viruses that can directly impact the brain. Today, we're talking primarily about sort of longer lasting and lower level cognitive difficulties, but about a quarter of patients who get stem cell transplant also experience something called delirium, which is a much more sudden and profound, but also reversible change in their mental functioning. But people who experience delirium are also at increased risk for some of these more long-term subtle cognitive problems. And then finally, people who experience graft versus host disease, that's another risk factor for cognitive problems. So it's all to say that there's sort of multiple potential contributors in this patient group. So I wanted to share next some findings from a small study that I published a few years ago. And so a part of that study was I evaluated patients right when they were admitted to the hospital for stem cell transplant, but before they had received the transplant. And I did this using a sort of brief cognitive screening test called the Montreal Cognitive Assessment. And a really surprising thing to me was that even prior to transplant, over 50% of people, as indicated by scores here on the left of less than 26, had what would qualify as at least mild cognitive impairment. But one thing to note was that only 5 of the 65 patients in this study had impairment that might be in the moderate range. So that fits some of what we've talked about already, that these cognitive problems are quite common, but usually more of the sort of mild variety. And then when I looked at, well, what factors seem to increase risk for people to be in this group of at least mild impairment? So these were folks who were older, who were men as opposed to women, who had fewer years of education, had experienced delirium at some time in the past, as well as people who had experienced different neurological impacts like strokes. But actually the strongest effects in this study of mine were that people who had multiple medical problems, those people were at risk for worse cognition prior to transplant, as well as those with a history of alcohol or substance use difficulties. So now let's discuss kind of what we see over time after transplant. This is from a larger study from a group out of the University of Washington. And the different plots you see here are just different tests of cognition. But you see a pretty consistent pattern regardless of what test is being assessed, which is that as you move from left to right with starting pre-transplant, that on the other side of transplant, there's a initial dip, initial worsening of function. And then pretty quickly you see a rebounding or improvement back to where you start. And then with time, in multiple areas of cognition, you actually see an improvement in cognitive functioning overall relative to where people started at the time of transplant. So I saw something quite similar in my study. So first starting on the left, you can see sort of where people started, that there was sort of this dip from the pre-transplant baseline to a month later, which was shortly after, at the end of their transplant hospitalization. But then as they were followed out for another 6 months or so, you see an improvement in cognition. And on average, that improvement, again, was similar, got them back to a similar place or actually even a better place than they were pre-transplant. And then you see a similar but slightly different story when you look at the proportion of people who were impaired. And so this is on the right here. So you might remember I said, okay, at, coming into the hospital before transplant, just over half met the criteria for at least mild impairment. And that number, that proportion of people who were impaired got steadily better over time, such that 6 months after transplant, we had 36% of people. So going from 51% to 36% of people are still meeting criteria for impairment. So then, kind of like I had with risk factors prior to treatment, I also looked at, well, what were the factors that seemed to predict, better outcomes with time? So people who were sort of more likely to improve over the 6-month period that we monitored them. So one thing that was really surprising to us at first was that people who actually had more aggressive cancers or who had a history of more aggressive prior treatments actually had greater improvement with time. And so it's totally, the opposite of what you would think. But I think the key here is what I referred to on the first slide when we started talking about transplant, which is that for these patients, the transplant is not the first thing that they encounter that's potentially harmful to their cognition. And so when people are going into transplant, they may not be starting in the best place, but they're still going to experience this overall trend to recovery. So basically, this group of people who had more aggressive cancers or more aggressive treatment just had more room to improve based on the prior exposures that they had. So by comparison, if we look at more sort of recent or proximal factors, we see what we would expect, which is that during the actual hospitalization for transplant, those who had less aggressive chemotherapies had more improvement over time. And then if we pan out to the rest of sort of the literature outside my specific study, what are the factors that seem to be most closely associated with or most predictive of people are going to have more difficulties after transplant? So age is definitely the most consistent predictor, where older age is a risk factor for worse cognitive outcomes after transplant. But there are a variety of other factors too that seem important. So for example, people who do not have a spouse or someone living with them in the home, they don't seem to do as well in terms of their cognitive function with time. People who have obesity or who are taking multiple medications that can act on the brain also are at risk for worse cognitive function with time. And then as it relates to sort of more cancer-specific factors, allogeneic stem cell transplant recipients as opposed to people who received autologous transplant seem to have worse outcomes, as do those who go on to develop extensive and chronic graft versus host disease. So now I want to talk a little bit about CAR T-cell therapy. And I'll say too, one thing that's just worth getting on the table is there's still a lot we don't know about the relationships between CAR T and cognitive outcomes, but I hope that in the next few years we'll understand this much better. So one of the things I wanted to highlight is that a possible complication of receiving CAR T is experiencing something called cytokine release syndrome. And so you probably know about this or have heard about this in other talks. But basically, this can occur when the CAR T cells recognize cancer cells and release very high levels of inflammatory molecules. And you can see changes throughout the body that include fever, changes in blood pressure, or oxygenation. But specifically in the brain, these high levels of inflammatory molecules can cause a sudden change in mental status that's called ICANS. Again, ICANS and delirium are not what we're talking about in this talk, but one of the things that I find interesting is that just like inflammation is the primary biological mechanism by which people think that cognitive problems occur in cancer in general, it's also the driver here in ICANS. And so when you think about potential links or potential risk factors of CAR T and more long-term cognitive problems, it seems like there could be a shared, underlying mechanism here. So for recipients of CAR T, what do we sort of see in terms of the impact of cognition? So there really have been, just a handful of studies that have looked at this, and it's mostly kind of in small groups of people. But like other aspects of cancer treatment, we see that patients have lower than expected cognition at the time of admission for CAR T. and that they tend to have a decline like at the time that they're ready for discharge. But that when you follow them out for a period of time, like 6 months or more, it looks like they actually overall don't have worse cognition than like where they started, or I'll just say, yeah, than where they started. But that you might see some variability in terms of aspects of cognition. So I haven't talked a lot about this, but there are multiple aspects of cognition, and some may be more impacted than others. And like a lot of other cancer treatments, it seems like sort of maybe up to a third of people will still have lower than expected cognition for sort of years after CAR-T. So here is just a figure from a study that was published earlier this year. It was from 106 patients who had received CAR-T, a little more than half of whom had lymphoma. But I'll clarify too that of those 106, they didn't get the cognitive testing done in most of them. So if you can see in the N number on the bottom of each bar, how many people completed these different tests or reported their cognitive function, which is on the far left, the perceived cognition. So just a few take-homes from this study. And again, we see there's a lot more of research needed in this area to understand kind of what the most common outcomes are after CAR-T. But in this study, you can see across the different aspects of cognition, no more than 20% of patients had a decline from pre-CAR-T to 6 months after CAR-T. And if you look at what areas were most affected, patients' own perception of their cognitive difficulties was the thing that was most likely to be impacted, and that was in 20%. But we also see that, like in this group of patients, 19% showed a substantial decline in their delayed memory over this period, and 15% showed a decline in executive function. Executive function is that sort of strategy or approach to which you might, attack a more complicated task. So coming back to inflammation, which I've mentioned now a couple of times as being sort of the most well-studied or understood biological driver of these cognitive changes, it's really interesting to try to connect some dots here, which is that inflammation itself increases risk for cancer, and also increases risk for cognitive disorders like Alzheimer's disease and other cognitive disorders. We know that inflammatory levels of inflammatory markers are higher even before cancer treatment in people who have been recently diagnosed compared to people without cancer, and that in general, again, across a wide range of research, that those levels of inflammation go up with chemotherapy, stem cells transplant, and during CAR-T. And those inflammatory levels do decline with time and space from those treatments, but even years later are higher than what you would expect for someone who didn't receive those treatments. And then the last piece of this is that the degree of inflammation has been shown, again, in multiple studies to relate to, worse cognitive function that's tested as well as reported. So just a broader concept I wanted to not spend too much time on, but highlight is, so inflammation is one specific biological mechanism. But another theory that's gaining a lot of traction is that cancer and cancer treatment accelerates the aging process. So we all know that with older age, all of our sort of cognitive abilities slowly decline, unfortunately. And so one thought is that cancer and cancer treatment accelerates that aging process throughout the body, and the decline in cognition is just how that acceleration is manifesting in the brain. There are a lot of factors that both worsen cognition and if they're addressed, can substantially improve cognition. And we'll talk more about those as we go on here, but just to highlight them, so sleep, mental health symptoms, pain, and pain medications, those all can worsen cognitive function. And when you think about ways to treat cognitive function, it's important that you're either addressing these first or at the same time, or you may not see the cognitive benefit that you're hoping for from treatment. Fatigue, abnormalities in things like blood counts and vitamin levels, those all also can worsen cognitive function. I don't want to spend too much time on this slide because we only have about 10 minutes left, but it's just to get across a couple points, which is, one, there are a few things that you come into your cancer and cancer treatment with that you can't modify, like factors about the cancer and how old you are and how many years of education that you have. And yes, the cancer treatment can directly and negatively impact cognitive function, but it also can negatively impact cognitive function through a lot of other pathways, like its impact on sleep or fatigue. And so again, that highlights multiple different places where you can intervene to improve how well your brain is working. I want to give you a sense of how we measure cognitive function. So a wide range of clinicians can do things like have you complete a survey to get a sense of how you feel like your cognitive function is. And they can also administer like brief screening tests like the Montreal Cognitive Assessment that I mentioned that I used in my study. That can give a pretty good initial sense of how things are going, but you can also be referred to see a neuropsychologist who would complete a much more in-depth evaluation that could give you detailed information, not just about whether or not your cognitive difficulties are in the sort of problematic or concerning range, but also some nuanced information about, well, what are the areas of cognition in which you're stronger versus weaker? So this is one of the survey measures I like. It's called the PROMIS Cognitive Function. It's 8 items, and it asks people to rate how often they notice difficulties in these different aspects of cognition. And one of the things I really like about it, other than it being informative about are people's cognitive difficulties sort of within the normal range, sort of mild, moderate, or severe, is it gives a lot more language for us to use in our visit together about where they're having difficulty. Because I think there is sort of a lack of language that people are familiar with in which to describe their problems, and so this can help give it a lot more dimensionality. I won't go through it because of the time, but this is sort of gives you a glimpse at what might be involved in that Montreal Cognitive Assessment. And now I want to pivot to talking about treatments. So kind of in terms of broad categories, we have cognitive rehabilitation, mind-body interventions, physical activity or exercise, and then medications as well. So there's 2 main categories of cognitive rehabilitation, and the first is called sort of strategy training. And this is something that a patient would work with a speech or occupational therapist on once a week, and in-person, face-to-face. And the goal of this kind of treatment is to improve awareness around where people are having difficulties, and then problem solve around how to compensate for those difficulties. And a lot of times that involves, figure out the best way to utilize things like planners, alerts, and sticky notes to maximize function. The second type of cognitive rehabilitation is called cognitive training. And so sometimes that's called like brain training or brain games. And this involves usually working alone, like on a computer, and doing sort of challenging cognitive tasks in 30-minute bursts. And here are 3 sort of commercially available programs, Happy Neuron, Luminosity, and BrainHQ, which have at least been studied somewhat in the cancer and cognition space. Exercise or physical activity, we know more and more is helpful for a wide range of symptoms in cancer, and there's increasing research to suggest that it can be quite helpful for cognition. In terms of mind-body intervention, so mindfulness and acupuncture both seem like they may be beneficial from some small studies. And then what's nice about mindfulness is that there are multiple different ways in which patients can engage with this. There's a pretty widely renowned program out of UCLA that anyone can sign up for. A lot of your local university might offer mindfulness programs through their integrative medicine departments and their wide range of commercially available apps. And then with medications, there's two main classes. The first is the stimulant class of medication, of things that are FDA approved for ADHD, and the second is medications that are FDA approved for Alzheimer's disease. But multiple of these medications have been studied in the cancer context, and though none of them appear sort of overwhelming in their benefit, they can help many patients. So finally, I highly recommend people consider things that they can do in their everyday life that can be quite beneficial. So one is enhancing, sticking to a regular routine. So that can be useful, as well as being thoughtful about, when people feel like their brain are working their best, and then trying to be really strategic about utilizing those times to do the most cognitively demanding work. I mentioned the use of external aids in the context of strategy training with an occupational therapist, but this is something that, a lot of us employ already and can get better and better at, again, to maximize function. And also say for people who, are working or want to get back to work, to recognize that there are workplace accommodations and to get things in place that allow you to function at your best at work is advantageous, obviously to you, but also to your employer. So to really not shy away from exploring opportunities that your work environment and work schedule could be modified to make things work better. So I'm going to skip sort of how I might approach evaluation and treatment, but there might be time for this in the Q&A. This is a book now about 10 years old that covers, much of what we've discussed today, and it's really written for patients, and so I'd highly recommend it if people are interested in learning more on this topic. And then just to close on a few key points. So cognitive difficulties are common before, during, and after stem cell transplant and CAR-T, but as evidenced by the sort of frequency of problems before these treatments, as well as the amount of recovery over time, the cognitive problems that patients experience are not specific to these treatments. And there are many medication, non-medication, and lifestyle strategies that can be helpful, as well as other factors that should be considered and treated to optimize cognitive function. So thank you.
Thank you, Dr. Nakamura, for this excellent presentation. Now let's take some questions. If you do have a question for Dr. Nakamura, type it in the ask a question box on the left side of the screen. We will answer as many questions as possible. Our first question is creative writing or art activities impacted as well by chemotherapy or transplant?
Yeah, that's a very interesting question. And I will say, I think that what I know most about this is from my experience working with patients. And I think it's been also very variable. I have certain patients who say that they really have difficulties in their everyday tasks, who still feel like they are able to excel in areas like creative writing and art. And then the other thing I will say is one treatment that I didn't talk about that has, is generally recommended is sort of like a writing or journaling, because getting practice with trying to communicate, concepts in a wide range of ways does seem to help with brain recovery.
Hey, what kind of skills are tested in the cognitive tests you mentioned? Are they math, reading, or reasoning, or just memory testing?
Yeah, that's a good question. It's really a wide range of things. Am I able to manipulate the slides still?
Yes.
Yeah, anyone know if I can move the slides? Okay. So what I'm going to do to try to help with this question is, so the MoCA test that I mentioned, it's a cognitive screening test, which means it's very brief and not very in-depth. But sort of each item on the MoCA reflects a much longer version of a test that you might do with a neuropsychologist. And so it gives you a little bit of flavor of the range of things that are tested. So in the top left here, they show circles with numbers and letters in them, and in the dotted lines show the start of a pattern. And so the person taking the test is asked to recognize what the pattern is and to complete that pattern. And so on a more in-depth neuropsych test, for example, not only would that be tested, but also the speed at which people complete it. Other things that are common in neuropsych testing are things like being able to remember a long list of words or to be able to recite numbers forwards and backwards. There sometimes is a language that's tested. And so, one way that's commonly tested is people are asked they're given a category like animals and asked to name as many animals as they can in a minute, or they're given a letter of the alphabet and asked to say as many words that they can think of in a minute that start with the letter F or something like that. And for each of these tests, it's pretty well established what might be sort of in the normal range for someone's, age and education and background, and what might be more concerning.
What do you test for inflammatory markers? Is there a blood test?
Yeah, great question. So there are multiple tests. In terms of clinically available tests that any that you can get at any doctor's office. So C-reactive protein is the most common in terms of ones that are both available and seem to be sort of meaningful to interpret. But then there are a lot of other inflammatory markers that are primarily reserved for the research setting.
The annual Medicare wellness visit includes a cognitive and a depression screening. Can you elaborate on these?
I have never participated in one of these visits, and I'd be interested in hearing more about the question. But my guess is that the cognitive screen would involve that Montreal Cognitive Assessment or one of the similar tests like it, like the mini mental status exam, or there's one called the SLUMS. And then for the depression screen, that is usually a sort of survey measure where you'd be asked just a few questions to get a sense of whether or not you're experiencing symptoms of depression.
Is there any research that shows increased risk of getting Alzheimer's disease after a stem cell bone marrow or CAR T cell therapy?
Yeah, that's a great question, and one in which there is a ton of interest. What I can tell you is that there is either no relationship, or if anything, and we don't understand why this is, that that there's actually a opposite relationship where people who are more likely to experience cognitive difficulties with cancer are actually less likely to go on to develop Alzheimer's disease.
Okay.
And
I
just want to add to that too. You know, one thing that I experience a lot clinically is that, you know, people who go through cancer treatment recognize that there are a lot of symptoms that they might experience afterwards, including potentially cognitive difficulties. But I think a lot of times people will come to clinic with really that specific question of like, do I have early Alzheimer's, or am I going to develop early Alzheimer's? So I think, you know, that's a really common and major concern for a lot of people. And, you know, for the vast majority of people, that's not what's going on when they're noticing difficulties with their memory.
Do cancer patients who self-report a positive attitude towards life do better in terms of avoiding aspects of cognitive decline?
That's another very interesting question. There is some research about sort of those personality factors, but not very much. But what there is a lot of research about is relationships between things like anxiety or depression symptoms and risk for cognitive problems. And what I can share about that is that people who are struggling with symptoms of depression and anxiety are much more likely to also report problems with cognition and be at risk for reporting in the future problems with cognition. There does seem to be also a relationship between things like depression, anxiety, and worse cognitive performance on cognitive tests, but that relationship is much weaker or less strong than with folks' own perception of their cognitive difficulties.
This is a memory question. What is happening with memory when you can recall a specific topic that was discussed but can't recall the details of the conversation? The example is that they know they need to get groceries, but they can't remember what groceries were discussed at home once they're at the grocery store.
Yeah, another I think common experience that people have is, you know, showing up to the grocery store, just a few things that they were meaning to get, but then they just can't quite recall it. And people who are clinicians who work in the sort of cognition world, they call this working memory, which is a little bit different than other aspects of memory, meaning that when you make a plan to go to the grocery store and get some things there, you're not truly committing those things to memory. You're just sort of holding them temporarily in the front of your mind or in the front of your brain. And that's what working memory is, your ability to kind of hold those things just long enough until you can kind of get rid of it. So it's a similar thing if like someone tells you a phone number, and then if you can dial that number. And that seems to be the aspect of cognition that is most impacted by cancer and cancer treatment. In terms of the other half of the question about like what's going on there in the brain to cause that, that's something that we don't understand as well.
Can cognitive decline get better over time and then decline again? Can there be like a roller coaster up and down with cognition?
Yes, I think that reflects the sort of multiple contributors to cognition. So I think in a vacuum, the effects of cancer and cancer treatment should improve over time, but you have a number of other, you know, sort of competing factors, and I think the biggest one is aging. So, you know, if you're 60 when you receive stem cell transplant, you might experience a dip in cognition that improves over time, but in the background, there's also the effects of aging on your cognitive function. So someone in that scenario might experience what feels like an improvement followed by a decline. And then, as I mentioned, there's many other things that could be contributing to more of like a up and down, like what's going on with sleep or what's going on with mood and those sorts of things.
Are there any differences in cognitive decline in somebody under 40? This person has noticed issues with memory and executive function decline, and it was very difficult after chemo. Is that normal? And when would this cognitive decline potentially improve?
Yeah, so I would say that, one of the things, for sort of simplicity in this talk, I emphasized that older age is a risk factor for cognitive decline. And that's definitely true of sort of tested cognitive difficulties. But when we just focus on the patient-reported cognitive function, we almost see the opposite, which is that younger folks are more likely to notice a decline in their cognition. And I think there are several reasons for that. I think younger people are generally starting in a better place. They are more likely to be doing things day to day that are more cognitively demanding of them, that they're more likely to notice. And then at the extremes, like people who actually have substantial impairment in their cognitive function sometimes aren't super aware of it. In terms of sort of what to do about this or think about it improving, again, I had to unfortunately skip sort of my approach clinically to this, but I think because there's so many factors, the thing that I've seen work the best for patients is to take a multi-pronged approach. So for the cognitive problem specifically, to get connected with a speech therapist to work on cognitive rehabilitation. I actually can't think of a patient who I referred to cognitive rehabilitation who didn't feel like it was helpful. And then for a subset of patients, potentially trying things like a stimulant medication or the medications that are used for Alzheimer's, but much more importantly, also looking at all those other factors, like, is there a nutritional deficiency that can be tested? Is there, mental health or fatigue or sleep issue that can be optimized? So when I'm working with patients, usually I'm trying to kind of do many of those things all at once.
Are there any sleeping medications that could interfere with cognitive health after treatment?
Yes. So sometimes folks are prescribed things in the benzodiazepine class for sleep. So some of the names of those medications are like Ativan or Xanax or Klonopin. And those can be helpful medications for anxiety and for some people for sleep, but those also definitely are known to have adverse cognitive effects. So when I'm working with patients who are on those medications, we work to try to transition off of them so that, again, we're minimizing any contributors that could have negative impacts on cognitive health.
Can you comment about current warnings about Benadryl and its effect on the brain? Is there any other substitute for allergy sufferers?
Yeah, so I don't think of Benadryl as maybe as bad as some of those benzodiazepine medications, but I appreciate the audience member bringing that up because antihistamines like Benadryl or other medications that have what we call like anticholinergic properties also are have negative effects on cognition. So Benadryl does absolutely. For the specific question about, well, what do I do if I have allergies? So there are newer medications, not so new anymore, things like Claritin that, work well for allergies and don't cross over into the brain as much and are more recommended for people who are trying to simultaneously manage allergies but minimize medications that could have negative cognitive effects.
What about trazodone that's been prescribed for sleep? Do you have any comments on that one?
Yeah, I utilize a lot of trazodone. I find that it's helpful. It does not have negative effects on cognition. I know some of my colleagues who are sleep specialists just don't believe that trazodone is actually that good of a medication in terms of its benefit for sleep. But I do use it a lot because in the patients I treat it, they do find it helpful, and it, again, is not a risky medication in terms of negative cognitive effects.
Does induction therapy for multiple myeloma qualify as chemotherapy?
It does, and you know, one of the things that you know, a lot of times the induction therapies are sort of high intensity therapies that require a hospital admission to receive, as opposed to something that folks would get in the outpatient setting. And those sort of higher intensity regimens that require hospitalization do seem to be more closely associated with negative cognitive effects than, you know, other aspects of cancer treatment.
Okay, you mentioned a couple of apps in the presentation to help with cognitive issues. Is there one that's specific for reading? This person has noticed their reading has become more difficult.
Oh, that's interesting. None of the apps that I highlighted, I would say, are particularly focused on reading. For this audience member, I actually think it could be helpful for them to consider getting a referral to neuropsychology, because there are so many different things that could be impacting their ability to read, and to better understand sort of what aspect of cognition is affected, I think will be helpful for this person to know what kind of a treatment might be most helpful.
Okay, this will have to be our last question. Have GVHD medications been found to prolong cognitive or memory issues? And then the second follow-up is, when they're stopped, is there a similar improvement?
Yeah, I think this audience member is probably referring to like immunosuppressive agents. And if that's the case, you know, I think that the relationship is not, you know, particularly well understood, but there is some research to suggest that they may worsen cognitive function, or at least in some subgroup of people. And I'm not aware of any research about, well, then what happens, you know, once they're stopped.
On behalf of BMT InfoNet and our partners, thank you, Dr. Nakamura, for a very helpful and informative presentation. And thank you to the audience for your excellent questions. Please contact BMT InfoNet if we can help you in any way.